Hello, everyone, and welcome to a very special Family Medicine VMR. We have a great session planned. So will the Family Medicine team unmute and introduce themselves?
Sure, I'll introduce myself. I'm Dr. Ramla Kasozi. You can call me just Ramla. Currently, I work at Mayo Clinic in the Department of Family Medicine as a senior associate consultant, but also actively working in hospital medicine as well as teaching residents. Some of you may know, I really love clinical problem solvers. I first did clinical problem solvers as a resident when I was at the University of Minnesota. As you can imagine, that those winters were a bit rough, so that's why I relocated to Florida. So here I am, looking forward to being involved again in this space.
Hi, folks. I just want to jump in. My name is Robbie. I'm one of the CP Solvers team members, and I'm super excited for this session and thrilled that we have Anne-Marie here pulling the strings behind the scenes and here to join us. Has been a pivotal VMR community member since day one or the early days with her partner, and now joins us as a facilitator in family medicine. We also have Simone. Simone Vase is a beloved CP Solvers team member who just texted me that her clinic is, look at that, she's here. Her clinic is running late, but she made it and snuck in. So I will let her in. And as soon as she's in, pass the mic to her. Hi, Simone. I think she's joined. There she is. I was literally introducing you and mentioning your name. Anne-Marie has been pulling the strings behind the scenes, and Ramla just said hi to everybody. We also have Dr. Neil Shah here. We have not introduced, just to orient you to where things are at. And I was just talking about you, and so I'll hand the mic for you to say hi.
Hello, so sorry I'm running late. My clinic was a disaster. I'm Simone. I am a second-year family medicine resident at UCSF and San Francisco General. I'm Robbie Juha's biggest fan. What else can I say about myself? That's probably it.
I don't know if I want to respond to that comment. She's not. She accuses me of bullying and many horrible things. But I would love to welcome Dr. Shah, who is presenting our case today. Do you want to unmute and say hello?
Yeah, hey guys, I'm Neil Shaw. I'm one of the first-year residents. I work also at Mayo Clinic in family medicine with Dr. Kasozi as one of my attendings. I'm fairly new to CPS, but I'm really excited to present a case today. Dr. Kasozi has been talking about it a lot, and I started watching some cases a couple months back, and I mean, it's been awesome. So looking forward to it.
Amazing. Well, it's an absolute treat to have you here. Thank you so much for the kind words about the podcast, and we're thrilled for anybody who is a new to the VMR space. Well, already I will revel in learning from you all, and we'll pass the baton to our facilitators, Ramla and Simone, to get the case going.
Wait, do we have anybody to discuss with us, or are we just discussing on our own today? What's the deal, Dr. Juha?
Oh, you get to choose, my friend. Whatever we've been doing both formats in VMR. You can choose to discuss solo. You can choose to discuss with specific people in the chat, or you can choose to highlight comments in the chat that come your way. It's totally your call. I think Dr. Shah has an amazing case. So either way, we will learn a lot, no doubt.
Well, it seems like nobody volunteered to hang out with Ramla and I. So I guess we'll discuss on our own and highlight amazing contributions, which will be sure to come in the chat. Ramla, are you okay with me going first and you going second?
Yep, go ahead. We shall do this.
But I'm searching for a piece of paper in this office that I'm stealing from somebody. All right, I'm ready.
All right, so Dr. Shah, go ahead.
All right, so this is a patient that presented in clinic about 1.5 years ago. Chief complaint of severe right foot pain for 2 days. You want me to keep going, or it's kind of broad?
An age bracket is all I'll ask for.
So a 49-year-old male, he's a fisherman. He works as a fisherman and he spends a lot of time on boats.
Awesome. Okay, so the complaint of right foot pain in clinic is so much of the time, I feel like something benign like plantar fasciitis or, some MSK complaint. And so I think when I have a complaint like this, I like to step back and just think anatomically, what are things that could be going wrong? And then layer on top of that, like in the category of people who are sick and fine, and then people who are, sick or people who are fine. So with the foot, we have the outer layer being the skin, which is something we'll be able to get information about pretty quickly based on your exam. And then one layer down, we've got muscle and fascia, which can have, typical things like sprains and strains, but can also have slightly more dangerous things like infections. We have got nerves running through there, which is, thinking about whether this person has diabetes or alcohol use disorder or any other sort of background history that might cause nerve damage or pain. And then we have bones and arthritides and fractures and other trauma. And then kind of in the space between the bones and the joint spaces, we have things like crystal arthritis and infectious arthritis, and then just regular old osteoarthritis. And so the range of pathologies that we can possibly have in the right foot are just so broad. And, I feel like you gave me a bit of a hint when you told me that this is something that's acute, and that you told me that he was a fisherman. So I won't go too much in that because I'll wait for you to give me information, but the fact that it's acute, if there might have been trauma, and that will sort of answer that question and make it a little bit less interesting, but things like neuropathies don't typically appear acutely. Things like arthritides in terms of like osteoarthritis don't necessarily appear acutely. Certainly crystal arthritis can, certainly septic arthritis can, certainly any infection of any of the spaces there can. So I think that's where you're leaving me.
I just noticed before you go ahead, Dr. Chow, somebody in the chat, I don't know if is it Jesmiran? I'm sorry if I'm saying your name wrong. Saying he had a interesting question. Sudden acute pain, can it be vascular? Are you willing to unmute and sort of discuss sort of your thoughts around that?
Oh, hello, everyone. Yeah, I'm sorry I cannot switch on my video, but we had a case. I think I presented that case 2-3 weeks before, and it was a case of an endocarditis. And when that systemic embolic phenomena, a complication in that endocarditis happened, so embolus was locked in the arteries of the leg, and that lead to the foot pain and the lower leg pain. And patient presented with right foot pain in that case as well. So when I saw a sudden acute history, I thought, could it be a vascular cause? Because vascular makes it more prominent for an acute pain to happen. So obviously I will be looking towards the vascular examination and physical examination. So yeah, that's one thing I want to point out. Thank you.
Yeah. Thank you for that contribution. Very excellent. Definitely one of the differentials. I know for me, like someone mentioned, like foot pain is just so common. I feel like I need to go, like there has to be a foot pain complaint that enters my clinic every week. And also for me, how I approach it, the same thing. Is it acute? Is it chronic? It also depends on location. I feel that's very important because where is the foot pain? Is it plantar? Is it midfoot? Is it posterior? Is it heel? So I look at that because that also determines sort of my differentials and how I move. And then also characterizing the pain, as we know, is it burning, tingling? Is it sharp? Is it dull? Is it something that's aggravated by a particular movement or not? So those are very important things, is definitely the location of the pain, how they characterize the pain, what worsens it, what aggravates it. But I definitely agree with the other way of how you can stratify in your head foot pain. You look at, is it arthritic? Is it infectious? Is it neuropathic? Is there trauma? Is it tumor or is it mechanical? And like we heard Singh say, is it vascular? So those are things to keep in mind. So I feel like right now with the information that we have, I still feel like we need more. We know it's acute, we know it's severe. But I usually still ask anyways, individuals, most of my patients, okay, I know this happened, but has this ever happened before? You know, you still got to ask that question and then they'll be like, oh yeah, I remember this, you know? So yeah, those are my thoughts for now.
I have actually a few more things to add, Ramla. After hearing Singh's comment about vascular, you totally reminded me that you're right. It could be an embolic event, but let's think about other vascular spaces that we should consider too. And those are the venous systems, both the superficial and deep veins. And foot pain might totally be a claudication in the calf. I'm sorry, like a deep vein thrombus in the calf that's causing pain that you're experiencing in your foot. And it can also honestly be a superficial thrombus in the foot. And so thank you for pointing out that it could be in the vasculature. And one other point I'll make is anytime I'm thinking about an extremity, I have to remember to think about the sort of the joints above and below. And so yes, the complaint is foot pain, but I want to also broaden myself to include the ankle and the knee, as those can certainly be the actual problems that the patient is just experiencing in the foot.
Oh yeah, definitely. And I see that Jenny in the chat mentioned, which I think is very true, that I know a lot of these cases are cool fun diagnosis, but I see a lot of people with foot pain with who just have unsupported footwear. And that is true. I agree. You know, some people here in Florida, I've noticed a lot of people just wear flip-flops all day. And I'm like, yeah, that's why you may have foot pain. But you also want to, you know, make sure you kind of rule out the big, bad and ugly thing. But that's a very valid differential as well as footwear. Okay, so maybe Dr. Shah, you can proceed.
Okay, yeah, definitely great discussion. So I'll keep going with the rest of the HPI. So again, a 49-year-old fisherman, new onset, sharp, severe, non-radiating right foot pain, 2 days after going deep sea fishing as part of his job. 1 day after he was deep sea fishing. So when he was fishing on the boat, he finished his trip, he cleaned the boat afterwards, had no problem that day. The next morning he awoke with this pain. 8 out of 10 severity, mostly on the top and the middle of his foot, associated with a little bit of swelling, able to bear weight, but pain was much worse when he was trying to ambulate. He felt like it affected his gait, where he couldn't walk his normal gait. No redness of the foot, denied any numbness, burning, or weakness. No systemic symptoms, no fever, chill, shortness of breath, or chest pain. No recent trauma to the foot or any excessive physical activity. Limited relief with NSAIDs and ice. He'd been using Advil intermittently with relief. You want me to keep going or?
We defer to you, friend, to tell us what you think would be the best discussion. So
then I'll go into his past medical history. So he has a medical history of cutaneous T-cell lymphoma, gout, nephrolithiasis, OSA, thoracic back pain secondary to a radiculopathy in the remote past, and then also a history of a left foot third metatarsal incomplete stress fracture 6 weeks ago before this foot pain. Family history. Oh, sorry. I was just going to say family history. Both parents have a history of osteoporosis. Social history. He was a 10-pack year smoker, but quit 16 years ago. Only drinks about 2 alcoholic drinks a week. Eats a lot of red meat with very little vegetables.
Ramla, you want to go first this time?
Oh, I was going to say you go. I'm still processing this information.
Okay, I'll just provide you my stream of consciousness. So, you know, with what you've told me so far, I still can't really answer one core question, which is this person sick or not sick? You gave me some signs, right? You told me that there was no redness, no systemic symptoms. So that kind of points me away from the general umbrella of inflammation, though I'm not sure I have enough information yet to inflammation, but I'm not sure you've given me enough data to say like, for sure, this isn't an infection, for sure, this isn't inflammatory. But you've pointed me away from it. And similarly with the trauma, you've pointed me away from some of the most common causes, but then you've given me a medical history, which has some richness to it. Firstly is the gout, which certainly you could anchor on here and say, oh, he has a history of gout. He's coming in with foot pain, though, you know, the top middle of the foot is not exactly where I would imagine gout to be. So that's a little bit less convincing. The fact that he has an incomplete fracture 6 weeks prior certainly raises my suspicion. And it's in his metatarsal, which is not exactly where he's describing the pain, but it's certainly it's feasibly related. And I'm thinking about ways it can be related. Is it not healing properly? Did that serve as like a nidus for an infection or an arthropathy? Did the fracture serve for that? So there's certainly things in his medical history that could be explaining what's going on. And the location, the top middle, what that makes me think of, you know, certainly the vasculature sort of passes through that area, the lymph passes through that area. It's not where I think of when I think of like the fascia. It's not where I think of when I think of like neuropathic causes of pain. So I would say, you know, without an exam, I can't make too much progress here, except for maybe some threads to pull me forward from his history.
Yeah, you mentioned some great points, Simone. Sorry, Dr. Shaw, clarify, is that it's a left foot metatarsal incomplete fracture, but he's having right foot pain now, right? So it's just
Correct.
Thank you. Thank you.
Okay, great. Okay. So it's almost like two different things happening, but in different feet or foots, whatever. Okay. So yeah, I mean, like Simone mentioned, especially when you have that pain, is it infectious or not? Is it trauma? Right now, I'm still on the fence of whether or not we're dealing with an infectious cause at the moment. Very, you know, usually you would have more signs, you know, there's something raging like red and sore and systemic illnesses or whatnot. I think the most, you know, like I said earlier, when you're stratifying foot pain, you kind of think of location. Now, the midfoot pain, most people like may have a presentation of like tarsal tunnel like syndrome. You know, think of it as like carpal tunnel, but you're having it in the midfoot area, you know, and I'm curious to know, I guess we'll learn later what the neuro exam would be like. So that sort of pops up in my head. I know he was on a boat and he was doing some activities, possibly, you know, all of those activities could have just aggravated a particular, you know, bony structure, to the point that compromising, who knows, the nerve area. I guess another differential, like, so that's where I'm kind of thinking, is there a nerve issue or is there a tendinopathy? You know, and that's also another thing I want to think about is like when you look at the anatomy of the foot, I mean, this is the most intricate like area I think of our body because we have so many small ligaments there that can constrain. And so having that exam of especially that midfoot area will let me know, okay, is there any like tenderness happening in the posterior tibialis or in, for instance, those really ligaments around the ankle joints, maybe that's where the pain is. So I'm thinking, yes, could this be a tendinopathy? Could this be nerve? Could this be like a bone issue that we don't know of? Definitely this guy is headed towards an x-ray. I know how I would approach the exam and you're probably gonna go talk about it. I use the Ottawa ankle rules. And so that's a very common thing in family medicine you need to understand to assess, you know, do I need to do an x-ray of the foot based on this? And it can let you know potential pathology. So the Ottawa ankle rules are very great to let you know, what am I dealing with? I still feel like I need more history just because I am concerned of that past medical history, whether or not something from there is creeping up and compromising sort of his right foot pain. I don't think it's gout, but of course, you know, when you're seeing like history of a lymphoma, you kind of get worried. So yeah, maybe you can continue and then give us some more on the exam. I don't know if there's anything, let me see what the chat. So somebody here, Sylvia mentioned, how did he get the metatarsal fracture? Could he have osteomyelitis? Sylvia, do you want to unmute and let us know sort of your thoughts, what you're thinking about, if you like? But it's okay if you don't want to. Oh, that's okay, no problem. But I appreciate, I don't know, Dr. Shaw, do you want to answer her questions? She was just wondering how the patient got the metatarsal fracture or.
So that's actually part of the case. So I don't actually want to go that far.
Oh, okay. All right, at least you're transparent about that. No worries. Okay, maybe you can continue to give us the vitals and then we can go from there.
Okay, so I'll just finish up the social history. So medicine-wise, he's on allopurinol for his gout, and he's taken multiple courses of high-dose steroids in the past for his T-cell lymphoma. So then physical exam, temperatures within normal limits. He's a little bit bradycardic with a heart rate of 52, but nothing concerning. Has a blood pressure of 159 over 101. Satting fine on room air. And then he has a BMI of 35. So general exam, he's in pain, but no acute distress. Neuro and hint exam is unremarkable. Heart and lungs are unremarkable, or the exam is unremarkable. No GI or abdominal symptoms. And then no neuro deficits, so no focal deficits. His lower extremity sensation, perception, everything is intact. So then I'll go on to the focused foot exam. So I'll first talk about his left foot. So this is the previous fracture, a little bit of edematous, some diffuse tenderness over the dorsal surface, but normal range of motion. And then in the right foot, so again, diffusely edematous, diffuse tenderness over the dorsal and the plantar aspects of the foot. No tenderness over the lateral or medial malleoli. No tenderness over the fifth metatarsal or the proximal fibula. No tenderness over the ATF or the CF ligaments or the PTF ligaments. Does have decreased range of motion in the right foot. He's hesitant to move it, basically inversion, eversion, plantar and dorsal flexion just because of pain. But no visible deformities, no bruising, no open breaks to the skin or lacerations.
Simone, you want to go ahead?
Sure. Okay, so cutting right to the chase, you give me some important pertinent negatives. Mostly, I don't feel like most of the things that would help me decide that I want an X-ray, you have told me are negative. So specifically, the lateral malleolus tenderness, the fifth metatarsal tenderness. You've convinced me that well, you haven't convinced me, but based on what you're telling me, I don't get a strong flavor of trauma. But now I've got to think about, where did this edema come from? And just a clarifying question, it's edematous, but is it red in edematous, or is it just like skin color in edematous?
Very mildly erythematous, pretty much skin color.
Okay.
Yeah.
And so now we have the bilateral feet are edematous.
Correct.
Okay, interesting. I am honestly not sure. Here are the things that are going through my mind. On the one hand, you're telling me he had a fracture on one side, he's having pain on the other side, he's having swelling, he's having a little bit of redness. Is he having some sort of exposure or like chronic traumatic events that are causing him to have perhaps not like one major trauma, but enough trauma to his feet that he's having this swelling and this pain? And having stress fractures? Does he just now have a stress fracture on his right foot like he had on his left foot? And we have to figure out which part of the story caused that pain. There's maybe something he's not telling us. I mean, common things being common, bilateral foot edema. I'm thinking about, venous stasis. I'm thinking about heart failure. That's honestly where bilateral foot edema would take me, but that doesn't quite match up for me with the rest of the story that you're telling me. And so I'm feeling kind of torn between these two threads of like, perhaps this is a systemic problem of volume, and that volume is collecting in his feet. And we need to think about the organs. We need to think about the heart, the kidney, the liver, like we do for any other cause of edema. And that's on the one hand. And on the other hand, I'm thinking, no, this is a focal problem of his extremities. He's having some sort of traumatic events. This is acute foot pain. Volume problems don't happen acutely in that way. And so I'm feeling certainly torn between those two. Ramla.
Yeah, I totally agree with you because, yes, we like to use Ottawa anchor rules, but this is the time where I feel I may break those rules because I feel like, there's something happening in that foot. So I'm between, could this be a lingering infection of sorts that is happening, causing the edema? You find that individuals, especially history of immunosuppression, maybe their ability to even mount an infection may be hard. So they can really be having some infectious process, but they just don't have the immune system to bring it out. Because we said that there is history of steroid use and, osteoporosis. And so that's my concern, that could there be an infection? Because whenever I think of joint MSK thing, the big, bad, and ugly you want to rule out is septic arthritis. That is what I want to make sure we're not dealing with. On your exam, it sounds like there was no history of like skin issues or skin puncture or whatever, which is good to know. But we also don't know as well as sometimes patients don't tell us everything. And so my concern is, could this be septic arthritis because of his history of being on steroids? Could he be so immunosuppressed that he can't even mount an immune response? So there could be an infection. Could he, of course, the steroid use have predisposed himself to like some sort of stress fracture of sorts or osteoporosis, and maybe there is a fracture, and we still need to do an X-ray of a foot, even though the Ottawa anchor rules say don't. So I'm now between kind of, is this an infection? Is this maybe trauma hidden, or is this an endocrinopathy of sorts that has caused the osteoporosis? Of course, his cancer history is also concerning. And yes, Davi mentioned quite rightly here in the chat that both parents had osteoporosis. I mean, could this be some hereditary thing that he's having? And yes, also just Miran, I'm sorry if I said your name wrong, but he mentioned that steroids can decrease bone density and increase propensity for fracture. So that is very true. Yeah, so those are my thoughts so far.
And if I could just add something, Ramla, this is leaving me with wanting to name this tension, which is that in clinic, this is actually all you have. Like anything beyond this requires quite a mounting of resources, right? So like at this point, you're at the end of your visit and you have to decide, like, at least where I work, am I sending them to the hospital to go get labs? Sometimes we can get labs in clinic, sometimes we can't. Similarly, we don't have X-ray on site. So are we sending them to the hospital to get an X-ray? Somebody mentioned an MRI. That's not something that we have the capacity to get stat unless we just say like, this is an emergency and like call in the troops, we're getting an MRI. And so I just wanted to name this tension of like, this is actually what you're sitting with. This is all the data you have, like how much more data, how important do you feel like it is to get more information quickly for this person? And I think everybody kind of varies with where they land. And I'll share where I'm thinking, and Ramla, I'd be curious for you. I think this is certainly somebody just based on his medical history that I would send to the hospital to get labs and an X-ray. I wouldn't pull the trigger for an MRI right now, but just because of his history and how this is unusual. And I think sometimes the tension that I feel with family medicine is that there's just such a breadth of problems people could be presenting with, that it's not always saying like, I know what this is, but it's saying like, I know what a lot of things are, and this feels like fishy, for lack of a better
Yeah.
term. Like this feels like something I can't put my finger on. And that feeling itself makes me want to get more information, because that's not right.
Yeah, no, I totally agree with you, Simone. It's almost like, you know, especially in our clinic, the same thing. I mean, if let's say this was your garden variety, you know, foot ankle pain, and you maybe it was sports related. I mean, this is a person where I'm like, okay, maybe you need an x-ray, PT, OT, slap on some Voltaren, and I'll see you in 4 weeks. And then you do that, and then maybe you're like, okay, if they come back and it's still worse, then that's when you think MRI. But that's assuming the patient is fairly stable, maybe not a 49-year-old, let's say even a 20-year-old. But I agree with you, especially with somebody with this really unique history. I can't explain just mild tenderness and swelling moreover in both foot, and a recent fracture, and now there's this right foot problem. I mean, this just screams septic arthritis or some sort of stress fracture. And this is a person where I would feel actually very comfortable in my setting. At least we're fortunate that they can do an x-ray, they can do some labs, and we can hold the patient and we can say, let's see how those are. And then if something is irregular, we can literally do a direct admit, which is kind of nice in our setting. Yeah. But some people don't have those resources, so you got to be mindful about that. Oh, Valerie mentioned something very interesting, quite the pun, a fishy case of a fisherman. I love it. That needs to be a tweet. All right, Dr. Shah, you want to proceed to labs and imaging?
Yes. Okay. So great thinking, great discussion. At this point, yeah, I mean, in the clinic, you could go a multitude of different ways. Got to make that decision. So I'll go to some of the labs first. So CBC was unremarkable. Metabolic panel was remarkable for it was a complete metabolic panel, mildly remarkable for an elevated ALT at 56, but very mild. LDH was within normal limits. And then uric acid was mildly elevated at 8.2. Then I'll go through some of the imaging. So I'll take a step back to the left foot. So when the left foot, the patient received that fracture walking to a football game, said he walked about 1.5 miles when he fractured the left foot. Initially got an x-ray about 3 days after the injury. It showed joint spaces were maintained, no changes, no fracture, dislocation. Patient was placed in a walking boot and then continued to have pain. About a week later, he reached back out to the clinic, was set up with an MRI. And at that point is where it showed the incomplete stress fracture of the third metatarsal. So then we fast forward to the right foot. So at this presentation, again, it was similar pain to the previous presentation. So we got a right foot x-ray. Again, no fracture, no evidence of a stress fracture, joint spaces were normal, mild soft tissue swelling. Then 5 days later, got an MRI of the right foot, and it showed a stress fracture of the proximal right fifth metatarsal shaft. So he had another metatarsal fracture, along with some soft tissue edema. So then we'll go to some more labs, further workup, right? So why is he having these two stress fractures? He's relatively young. He does have a lot of physical activity, but it's more, weight bearing. It's not physical activity. So he shows up for his annual a few months later, again, wanting to talk about it. So then he gets worked up for osteoporosis or an endocrine disorder. Over the next few months, bone mineral density scan shows osteopenia of the lumbar spine, but normal hip, normal leg bones. TSH was within normal limits. Lipids were slightly elevated at 243. Vitamin D2 was a little bit low at 4. D3 was normal at 35, and total vitamin D was within normal limits at 35. Urinalysis was unremarkable. Did a supersaturation profile on his urine due to his history of gout. Was found to have elevated urine phosphorus at 1,210. His calcium was high end of normal, but it was normal. Magnesium, potassium, sodium were all within normal limits in the urine. Did an ALK phos, an SPEP, TTG that were all normal. PTH was normal. Found to have low bioavailable testosterone at 37, and then low total testosterone at 186. Prolactin, FSH, LH were within normal limits. So I'll stop there. That's a lot of information.
Yeah. Simone, you want to go ahead? What are you thinking?
Oh, I absolutely don't want to go ahead, but I'll just start talking. Okay, well, starting at the top. So in terms of the CBC, the white count almost reassures me that there's no infection, but then I remember to keep in mind that, oh, this is for an immunosuppressed person. I can't totally believe that. But the white count was normal. The hemoglobin, there's not an anemia, which is relevant mostly because I'm wondering if there's like a chronic inflammatory condition present, and the lack of anemia kind of helps me feel better that there is not. The normal chemistry reassures me that we're not dealing with a renal cause of volume or liver cause of volume. Doesn't tell me much about the heart, but my suspicion for that is low. Uric acid I don't find to be super helpful in thinking about gout flare, so it doesn't particularly push me one way or the other. The MRI showing the stress fracture pivots our case to thinking about, why does this 49-year-old man have stress fractures? Now, it's true that he's had exposure to steroids, but when I think about my patients for whom I'm like monitoring for osteopenia in younger ages, there are patients who are like on chronic steroids for long courses of time. My sense from his history, and correct me, was that he did have, several steroid bursts, but he's not somebody who's on daily steroids for years. And so I'm not convinced that I can chalk up his stress fractures and his osteopenia just to steroids. It makes me want to investigate further, and investigate further you did. The low vitamin D, a borderline low vitamin D is not convincing to me that we have a good answer. A normal ALK phos, that surprised me a little bit when I got to it, because I think of ALK phos as being something that I can expect to be elevated in diseases that have a lot of bone turnover. And so the presence of 2 stress fractures with a normal ALK phos makes me think maybe there's not a huge amount of other fractures going on, or a huge amount of other bone turnover going on, but I'm still really thinking about how to interpret that. Multiple myeloma crossed my mind as we were thinking about issues of bone lesions, but the SPEP were normal. Other things that cross my mind, or somebody asked in the chat, how do you think about the cutaneous T-cell lymphoma in the context of this? And so, I'm not sure. The way that I initially thought to think about it was, okay, well, what does the imaging show? Does the imaging, apart from the fractures, show lesions of any sort, any like lytic lesions of the bone that might account for areas of weakness that might be nitises for stress fractures? Beyond that, I don't have a great approach to lymphoma, so cutaneous T-cell lymphoma, and so I'd love some help thinking through that. And then similarly, like I know that low testosterone feels right to me that it's correlated with fractures, but to be totally authentic, I would need to look up kind of the mechanism for how that happens and how that pushes you further. So Ramla, please fill in the gaps in my knowledge.
Yeah, I'll try my best as well. Very interesting case. Definitely at this point, yeah, there's sort of kind of the buckets I was thinking. Is this infectious? Is it traumatic? Is this endocrinopathy kind of thing? Or is it like a malignancy? That's sort of my 4 areas of the buckets. Right now, infection possibly, but I don't want to ignore it because I got to still keep that in the back of the head. I mean, we did an MRI, so it would have told us if there was like osteomyelitis. So that's why I'm like, okay, maybe it's not really an infectious in origin, because that MRIs are pretty good at picking that up. The other thing I think where I'm concerned about as well is like, his history of cutaneous T-cell lymphoma. I mean, way back when, I just kind of remember reading about sometimes people can get skeletal manifestations of T-cell lymphoma. I don't know how common it is, but they may get the lytic or the blastic or even sometimes osteoporosis. So could there be a resurrection of that happening? Do we need a bone biopsy? I mean, like that's the only, or bone marrow or something, like that, or bone marrow biopsy to figure that out. Yeah, the low testosterone kind of threw me off, I'll be honest. And so I'm also trying to figure out, is there some sort of like axis that is responsible in that area that may hinder, or predispose somebody with also like osteoporosis or whatnot. Somebody in the chat mentioned high urine phosphorus is due to increased bone resorption. Do you want to unmute and sort of share your thoughts about that? I think it was just Miran, and what you were thinking about that.
Also, I was just thinking, like, is the high urine phosphorus because of the increased resorption of the bone that is having multiple stress fracture and decreased bone density? Or is there something else? Like, I don't know, like urine phosphorus in urine can increase, might be due to the kidney problem or to do the gut metabolism. That is why someone asked for, AMK asked for the serum phosphorus as well in order to compare. And I agree with you regarding the endocrinopathy. So all these things can fit endocrinopathy, and we can, as you talked about the excess, so we can definitely start looking from the higher level, which can lead to the increased secretion of testosterone. So might get an imaging for the pituitary gland or might be parathyroid gland, because these can be culprit which can fit the phosphorus and testosterone as well. So yeah, that will be my thought.
Oh, and Jenny also mentioned male hypogonadism can increase risk of osteoporosis. Ooh, Jenny, do you want to unmute and share your thoughts about that, if you're able?
Well, I Googled it, and that is what PubMed told me.
Okay, at least you're honest. That's fine. But yeah, that's a great catch. All right, excellent. I mean, it is possible, because that's sort of where I was as well. I'm like, there's a reason for that low testosterone. And I was trying to think back, okay, looking at my axes, where in the axes is it affected? Is it up in the, pituitary hypothalamic area? Do we now need to image the gonads? Do we have to now look at other hormones? Because this is suspiciously low in the setting of a really young guy acting like an 80-year-old woman, just, having all these fractures everywhere. So AMK also mentioned, also curious about the FGF23 level, if low serum phos. AMK, do you want to unmute and share that? I don't know, what is FGF23 level? I've never heard of that.
Yeah, it's a fibroblast growth factor 23 that can also sometimes be like expressed in lymphomas and can cause low phosphorus levels that can lead to fractures. I don't know a lot about it. I would just be kind of curious if there was a low serum phos about that level as well.
Oh, wow. Well, thank you for teaching me. I didn't know about that. Dr. Shah, any insight on that? Did you look into that? Oh, you're muted.
Serum phos was actually within normal limits. It was a little bit on the lower side, but it was within normal limits. It was at 3. Did not get an FGF23 level. I also was not aware of what that was.
Yeah, so I have not, I'm going to do my homework. I definitely have to do a lot of reflecting after this case. So Dr. Shah, you want to, is it okay to Simone, do you have anything to add? Should he just take us home? All right, let's go. Take us home and reveal.
All right, so lots of good thoughts again. So patient was referred to endocrinology for the workup of the low testosterone. Testicular ultrasound showed that gonads were normal size. However, repeat testosterone was low, and patient was diagnosed with eugonadal hypogonadism. So now we were trying to wonder what is causing this hypogonadism. So I'll just, take us home. So it was chalked up to a variety of factors, and I thought that was kind of interesting. His obesity, so if you remember, he had a BMI of 35. Obesity can cause releasing leptins and interleukins, which can suppress, like we were talking about, the pituitary hypothalamus axis. It can affect that and suppress gonadotropin releasing hormone, which affects sex hormone binding globulins. Another thing, he had OSA, again, which can cause low testosterone. And then the high dose steroids. So he actually was on multiple months of steroid therapy with like intervals of no steroids. So it'd been like a four-ish year where he was on steroids for 2 to 3 months, stopped for about a month or two, was on steroids for 2 or 3 months. And so it was interesting because the final diagnosis, we kind of attributed the low testosterone to all of those factors. He was started on androgel, topical patches. He did lose some weight, and his testosterone over the past, about a year later, he has been within normal limits. His apnea has gotten a little bit better as well. No more fractures. I'm not sure if he's still a fisherman or not, but so yeah, it was a pretty interesting case.
That's a phenomenal case, Neil. Thank you so much. I'm just so struck by how a concern that is like a concern that I agree. I see at least like once a week in clinic led down a path to a diagnosis, which couldn't have been further from my mind. And probably if I sat here for 3 hours, I still wouldn't have gotten there. And the journey was so interesting. And I'm curious, over what time course did you get from his first visit to that diagnosis of primary hypogonadism?
It was about 13 months.
Wow.
Over a year.
Yeah. And I think that's the other like tension I want to name, but also like appreciate is how the experience of diagnosing something complex like this is so different when you're doing it in the outpatient setting, where maybe you get one new piece of data each month, as opposed to a ton of new data all at a time. And, I'm sure that interspersed with all of these pieces of data that you got, there are other concerns that he had, just run-of-the-mill concerns that we all have. And so figuring out what's signal and what's noise is like even more difficult when you're getting them over getting all the data over a long period of time. So thank you so much for this case. I too am going to go read a lot.
Yeah, thank you, Dr. Shaw. It was a great case. I appreciate you being a trooper. I know you've had a busy inpatient peds, but this was excellent. Definitely one of those things in family medicine where I like the fact, though, at least we were able to follow this patient and we insisted and tried to figure out, okay, what is really happening? But yeah, this is, family medicine, which is kind of cool. You get to see that outpatient stuff. And did he ever had to get like admitted to the hospital, or all this was done outpatient wise, right?
All done outpatient.
Oh, thank God, blessings. So, and that's the thing why I enjoy family medicine. We really try our best to avoid people getting into the hospital. So if we can try to do as much as we can outside, that'll be great. I mean, Dr. Shaw and I were lucky. We have the luxury of Mayo Clinic. So there's a lot of things around us and resources. But like Simone said earlier, there are places, in this country where it would be very hard to get from point A to B. It might even take another year in other places if it took us a year to do this for this patient.
And I want to say that, like, you can totally imagine a world where this person had the second fracture, the fracture was treated, and nobody dug any further, like without some continuity of care to kind of put these pieces of the puzzle together. You can totally see where this story stops at the second fracture.
Oh yeah.
And this person actually never gets their diagnosis, never gets a treatment that makes them feel better. So I think that's pretty remarkable.
Yeah, definitely. So thank you for sharing. I guess, who will summarize the case for us and the teaching points? Is it Madalena? You're ready?
Yes, definitely.
Okay.
Amazing case presentation and discussion. I learned so much. So to start off, I thought it was really helpful to think about, such a broad chief concern as right foot pain, and to take a structured anatomic approach. So we talked about, you can first think of the skin, then the muscles and fascia, thinking about sprains and infection, plantar fasciitis. You can think of the nerves, thinking about diabetes, even alcohol use disorder, moving on to the bones like osteomyelitis, and then of course joints. So wanting to rule out the different types of arthritis, septic arthritis, crystal arthritis, and then you can even think about the vasculature and the venous system. So things like claudication and DVT. And also when a patient comes in with localized pain to, for example, the right foot, you definitely want to consider joints above and below. So things like the knee and the ankle. So besides the anatomic approach, you also want to consider kind of the time course. So breaking it up into acute, subacute, or chronic. So a more acute presentation of right foot pain, you would want to prioritize a septic or crystal arthritis that you wouldn't want to miss, versus more chronic causes would be something like neuropathy. And a very helpful kind of large buckets to consider when you're framing your differential would be infection, endocrinopathy, in this case, malignancy or autoimmune. And then we talked about really important parts of the history to elicit. So the location of the pain, which can inform your differential. We talked about midfoot pain, being a sign of tarsal tunnel syndrome, as well as really making sure you characterize the pain well. Things, things like what is the pain aggravated by movement, dull, sharp. We talked about the Ottawa ankle rules, which are a series of guidelines that can inform your decision about obtaining an X-ray. And then kind of jumping to, I thought this was a really interesting point about kind of the tension and decision-making at the clinic that, in contrast to all the resources that you have in an inpatient setting, when you're at the clinic, sometimes there's a kind of a conflict that you have to reckon with. Is this a problem that can be managed in the outpatient setting, or do I need to kind of mobilize more resources, get the patient to a hospital setting to get more labs and imaging? And no clear answer there, but it's something that's just important to think about in this case, especially. And then lastly, we ended with the primary hypogonadism secondary to these various factors: obesity, osteoarthritis, chronic steroid use. And I think it was Robbie in the chat who put in this link to MOSH, male obesity secondary hypogonadism, which just from a quick research, is a syndrome that impairs fertility, sexual function, and bone mineralization. And definitely have a lot more learning to do on that topic. But thank you all for an amazing, amazing case.
Before we end, sorry, we forgot about the problem representation. I don't know if Dr. Shah wanted to just kind of summarize that, if you can, and then Madalena, if you're able to type that. Or
okay, so problem presentation, 49-year-old male with a history of gout, obesity, and incomplete metatarsal stress fracture, as well as cutaneous T-cell lymphoma, presenting for these recurrent stress fractures, found to have osteopenia secondary to low calcium in the setting of a testosterone deficiency, likely secondary to mainly obesity.
All right. Well, thank you so much. This was a great turnout. I hope everyone enjoyed themselves. Any last words, Simone?
No, thank you so much for everybody for coming and adding your wisdom to our conversation, helping us think through this. Certainly felt like a team sport on this one.
It did. All right. Thanks, Nia. All right. Take care, everyone. Good night.
Thank you guys so much.
All right.